non-motor symptoms could be sweating, anxiety, panics. So that could be a sign of a non-motor sensory off. And there are different reasons why folks develop off. There are central reasons and peripheral reasons. So central reasons have to do with the buffering capacity, in the sense that as disease progresses, folks have less and less remaining dopamine in the brain, and they rely more and more on the dopamine that you take in form of tablets. So essentially, when the medication stops working, then you really don't have any reserve, if you wish, or less reserve your own dopamine, and that causes this off episodes.
This can't be overemphasized, how important it is for people with Parkinson's to move. We talk about different treatments, we talk about different medications, but we all know that patients or people with Parkinson's who move and exercise do better than people who don't. And so anytime you can move instead of not move is going to be helpful to your day. Decreasing stress, sleep. Sleep, we all know, is vital to feel good. When you get a good night's sleep, you feel good the next day. If you don't get a good night's sleep, you don't feel good the next day. And of course, sleep itself can be impacted by Parkinson's, so that can be a tricky balance. Good bowel function. Again, if you feel like you're clean and your bowels are moving, you feel good. The medications can move through your gut and they can be absorbed properly. When everything's stuck, you feel kind of stuck and lousy too. And again, bowel function can be impacted by Parkinson's, so it too is super important to control. Hydration, staying hydrated, making sure your blood pressure is good. Again, people with Parkinson's can have low blood pressure. When you have low blood pressure, you can feel weak and dizzy and just lousy. And so maintaining your blood pressure, one of the ways is with good hydration, can be really helpful for your day. Other things like social interaction, humor, love, optimism, and laughter. Whoever put this list together, I love it. And all these things can feed into making your day the best that it can be. So on that note, I'm going to ask our audience for any questions that you may have, and we'll use those questions as jumping off to further discuss the on-off phenomenon or other issues that may be related to medication and how to achieve a good balance in life with Parkinson's. If there are no questions, I have a lot of questions here that we can use as well, so don't feel any pressure to come up with your own questions, but we have one already.
Regarding the on-off situation. Regarding the on-off situation, you ever increase the dosage?
Either one.
So that's actually a very good question, because it's very educational point here. So one has to realize that increasing the dose of medication will not make it last longer. This is a very important point. So one has to either add extenders, as Dr. DiRocco mentioned, or put doses closer together, or use some rescue medications. But increasing each individual dose will make it work harder. I mean, it will work better during that time when it works, but it's not going to last longer.
Yeah, question.
Is it possible to take too much Gilbert at any one time? If I'm not sure if I took it and I double up on it with no harm. For any reason.
Well, it's a good and important question. And the premise to this is that each and every person is unique, and each and every response to the medication is unique. In general, we emphasize, being on schedule, being on time, especially when you have a short duration from the drug. Being even half an hour late can kick an off time. But it's a common question. Life happens, you forget, what do? I was supposed to take the pill at 2 o'clock, it's now 4 o'clock. What do I do? Do I take? Don't take? Wait until 5, and so yeah, the good answer is common sense. So, if you really feel that you're in an off, you take the pill, and then maybe you can delay a little bit. But your question is, it's further than this. Is there too much levodopa one can take? Yes. Sometimes if you take too much, other, 2 doses together, 3 doses together. Or in general, if you take too much, they may not be good for the brain. There may be side effects to that. Can affect blood pressure, can affect the clarity of mind. So most of the time, if one takes an extra pill, that happens, except some bad noise. But it is wise to be sort of careful with the dosing of the drug.
Okay.
I have a question about a person with bowel movement and very constipation frequently and severe. Is there any methods or any drugs that can deal with that? Basically, it's still very difficult. I think that affects absorption.
Yeah, absolutely. So constipation is an extraordinarily common, what we call non-motor symptom of Parkinson's. So we've been discussing this off and on, which is part and parcel of treating the motor problems of Parkinson's. So the motor problems of Parkinson's are the tremor, the slowness, the stiffness, the problems walking, the things that people can observe about a person with Parkinson's, how they move, they're stiff, they may be stooped. But there's a whole other world of Parkinson's symptoms, which are called the non-motor symptoms of Parkinson's. And they are as important, and in certain cases, in many cases, more important to affect quality of life than the motor symptoms. And we categorize these symptoms into different groups. We have symptoms that affect sort of the neuropsychiatric elements of life. So that would be mood, sleep, cognition, potential for hallucinations, that sort of group of symptoms that could be very problematic. We have a group of symptoms that are called autonomic symptoms, and those are symptoms that are body functions that you don't have conscious control over, and that would include gut function, urinary function, swallowing can be included in that, blood pressure control. And then there are other symptoms such as lack of smell, pain. There's a whole bunch of these non-motor symptoms. And one of the most common ones is constipation. So it's to the point that if somebody comes to your office with Parkinson's and they don't have constipation, you're like, wow, that's really surprising. Constipation is so common. But the great thing about constipation is that it's treatable. In most cases, it is treatable. So how do you treat constipation? So luckily, treating constipation in Parkinson's is very similar to treating constipation for any cause, and it is something that's very common in the general population. So you start with lifestyle modifications, and this probably isn't going to help the particular person being asked about, but it's certainly important to mention. So making sure you're exercising. If you're sitting, your bowel's not moving. When you exercise, your bowel moves. Exercise really helps constipation. Making sure you're hydrated. If you don't have water in your gut, then nothing's going to move. So definitely must keep hydrated to have good bowel movements. Then there's different foods that maintain motility. Some people swear by papaya. Some people swear by kefir yogurt drink. Some people think kiwi does it for them. There's different foods that people have found. Adding mineral oil to your food can help things move. There's a recipe called the Rancho recipe, which is a combination of bran and applesauce, and I forgot what the third one thing is. Anyway, this recipe, which you take every day, can help you go. Foods with fiber to bulk up the stool and make it easier to go. So making sure that your diet is full of things that are going to help you go. And so that is very important. So really just planning your day, making sure what you eat and what you drink and what you move is going to be good. It's going to go a tremendous long way to help with constipation. If that's not enough, and it often isn't, there are multiple over-the-counter medicines that can be tried. So there are stool softeners. There's some stimulants like Senna. Colace would be the one that's a stool softener. Those work really well. Miralax can be amazing. It's a powder that you can buy in the pharmacy. You can put a capful in 8 ounces of any liquid you want. It's tasteless. You drink it every day, and it really can be very, very helpful. The important thing about constipation is you don't want to actually get yourself out of constipation, you want to prevent constipation. Once you're stuck and there's like lots of stool in there, it's much harder to get it out than when you don't have it to begin with. So taking something every day may be necessary. And sometimes if you're totally stuck, you just have to have it, go to the doctor, get emptied, and then start again, to take something every day. So it's kind of important to make the gut really empty, and then you may be better off. So now that, you've exhausted lifestyle modifications, you've exhausted everything in the pharmacy, there are prescription medications. So they are not particularly approved for Parkinson's disease constipation, but there are at least 3 medications, I think now 4 medications that are prescription medications to help for constipation. So if you are not getting relief in any of those other methods, and you really want to try all of those first, you can get a prescription. And after all of that, you should have relief. Very long answer.
Can I ask a question? Are you aware of any research for leading a whole food plant-based diet in Parkinson's?
So, this is very quickly. So yeah, there has definitely been studies on the Mediterranean diet in Parkinson's disease. So there's been a lot of studies on Mediterranean diet and a sort of sister diet called the MIND diet in brain diseases in general. And it definitely correlates with good brain health. So the Mediterranean diet would be mostly plant-based, low-fat proteins, if you have any, which are fish and chicken, olive oil as the main fat, and nuts and legumes, etc. So that diet actually was one of my favorite papers. Is a paper where they looked at the adherence to Mediterranean diets in people who already had Parkinson's disease, and they found that people who had who reported adherence to Mediterranean diet, their Parkinson's disease diagnosis was delayed by 17 years over the group that didn't. So these are all people that had Parkinson's, but the group that adhered to the Mediterranean diet had this incredibly delayed onset of disease. So yeah, diet does a lot of good things.
Hello. Thank you for coming. You guys are amazing. And that's everyone. If a person had DBS procedure, as I have, and I know that the body the carbon level is going down, right? Don't you have to take supplements with some? I mean, should there be some anything now? So I started taking half a carbidopa pill a day, because I figured if I'm not producing dopamine, shouldn't I be having some? I don't know. So I know it's not a question.
No, it's an excellent question.
I just want to clarify, make sure that I understand correctly. So you're asking whether, if you had the DBS, whether you're supposed to be taking levodopa in addition to that, or?
I think it is a depletion. I'm taking a little bit.
Right. Okay. So basically, what DBS is a surgical treatment for Parkinson's disease, as you know, it's not a cure. And once you have DBS, you're able to reduce your levodopa by from 25 to 50%, depending where. I had a couple of patients who were not taking any after the DBS, and some of them were misled. They thought or misunderstood it. They thought it was a sort of a cure, or they would never need to take levodopa. It's not correct. You actually, at some point, might need levodopa. Absolutely, but the dose of that levodopa would be less as opposed to if you hadn't had the DBS. But the DBS or levodopa, for that matter, they don't help certain type of symptoms such as balance. Balance would not get better from either. However, the motor symptoms such as tremor definitely is alleviated with DBS. But nonetheless, for reasons that we don't quite understand, I have not seen a case where someone was able to just have DBS for, let's say, 20 years without having any levodopa at all. The longest I've seen patient probably would say 5-7 years. They only have DBS and nothing else, but then eventually they had to add levodopa as well.
And is there any, because I know if you want to take it, every once in a while I feel like tremor, I don't see it really. So I decided, oh, I want to take half of 2,500, for whatever, and it seems to do fine. It's all individual, so I have no solution. I just want to be here for me, not for everybody, obviously.
Right, everybody's.
But it makes sense after a period of time to start taking, because you have a lack in your brain.
Right, and also there's only a limit on TVS, how much stimulation one can receive from the electricity.
Right, how long does the DBS, I mean, how long does it last? I mean.
Lasts forever. I mean, it works as long as the battery is working.
Right.
But again, you have to have realistic expectations in terms of what it can and cannot do. So obviously for tremor, it will work forever. For stiffness, slowness as well, but for balance, it doesn't do anything. For speech, it doesn't do anything. Memory is not getting better from that. So as long as we know what to expect from that, from DBS, then we're fine.
I'm not complaining. Well, thank you very
Of
much.
course.
Yes, hello, everyone. My name is Jim from Chicago, and I recently had DBS surgery, and I will follow the Simone just made. Everybody here that has Parkinson's, I'm sure just yearns and wishes to be how they were pre-Parkinson's. And we just want to be normal. And the longer you have the disease, the more side effects you encounter. One of them being dyskinesia, and I didn't even know I was on a really high dose of Rytari, 585 milligrams. And I had all this dyskinesia, and that's people's first judgment, not in a malicious way, but it was, what's wrong with this guy? And, sorry for stumbling over my words, but, is there, things the doctors on the panel that opine on, is there a preferred window of time in which to pursue something like DBS? And I went through it myself, and I put it off. I was afraid of it, and when I actually went through with it, I'm like, what the, this is no worse. No, be honest. And you bet on science, you bet on medication, and but is there a preferred window? For myself, I was first diagnosed with heart failure at age 50, and I went to the DBS surgery, and I got COVID a short time after I was activated. And I slept all the time during COVID and didn't take any medication. I really hate being tethered to the bottle of pills.
So did you wait too long is your question? Like,
Yeah.
That's
And I waited 10 years to turn age 60. It really wasn't that bad. Everybody thinks that DBS is the last hope that the heart's done.
and you shouldn't be the last thing.
Right, and I think most people who had it, did you have COVID that I was doing that there?
So,
Yeah, there's this fear.
yeah,
I
so,
want to get my brain drilled.
yeah,
It's
so yeah,
changing me.
I think you're totally right, that there is a fear, and understandably, it is a big deal. I mean, when you're on the other side, you compare it to root canal, but bottom line, it is a little more invasive than that. You are putting a wire in the brain, and there is a risk of bleeding or stroke. So a small risk if you go to a center that does a lot of surgeries. And you do want to go to a center that has a lot of experience, and then the risk is quite low, but it's not zero. So, you do have to consider it. So I don't think your waiting was, a problem. Everyone is different, and you need to come to it in your own time. Having said that, you are now able to give your experience, and it's your experience. It may not be someone else's, but your experience is that sounds like you felt like shouldn't have waited that long, or you shouldn't have been so hesitant, and that kind of experience may be helpful for someone else to hear. But I wouldn't doubt yourself, because in those 10 years, that was an important process you needed to go through to get to the point where you were ready. So I think you've come to a good place. So thank you for sharing your experience.
When should you start taking the medication? I was diagnosed about 2 years ago. I have minor tremors in my right hand, and I feel fine in my abilities to do still what I consider a normal life. But slowly I'm getting worse. But I think part of the is not taking the medication, right? The medications, as you see, to get used to it, you have to take more and more as time goes by.
Well, the general principle is that, the medication helps improve your quality of life. So if your quality of life is pretty good, if you're doing everything, if your life is not disturbed beyond, minor annoyance, then there's probably no need to take the medication. On the other hand, if you start to change your life, not doing certain things, and there is one element which is, I think, is particularly important. If you start sort of changing your life and you're not doing enough to be active, as Dr. Gilbert was mentioning, one of really the biggest discovery in the last 30 years of Parkinson has not been any major scientific breakthrough, but the understanding that if you don't move, the disease will have a much worse course than if you are active and exercise. Well, that for me is an important time when I really feel like, if you start becoming sedentary because the symptoms are so troublesome that you don't want to walk, you don't want to go out, you are subconscious, or you have trouble, doing things for yourself. That's a good time. That's the time to start the medication. So there isn't an absolute formula. There is no such a thing, at 6 months after the diagnosis, a year, and so on. Also because keep in mind that, and I think everybody here knows, that the disease can have a very different course in different people. The people who have a very mild progression of the symptoms, and people for whom the progression is not as mild, in which there is an evolution that is different. So it's really dictated both when to start, what to start, and the dosing related to quality of life and the symptoms that you have.
Is there any advantage to taking the meds on an empty stomach? Does that matter?
Yeah, it's actually a very good question. I'm glad that we did that question answer session, because you're essentially prompting us to discuss things that are very important, and we would have discussed it anyways, but coming from you, I mean, it's really good to hear that this is what you're interested about, because it is important. So basically, we're talking about carbidopa, levodopa specifically, because that's the only medication that has to do with whether you have food or not. And if you take carbidopa, levodopa with animal protein, such as meats of any kind, including fish, poultry, then the meats will compete for your gut essentially, and that would deactivate or reduce effectiveness of levodopa. That pertains only to animal protein, but yogurt, eggs, not so much. And if you do have meats, then I would rather you take medication 30 minutes before your meal or an hour after. However, in terms of other type of food, in carbohydrates, vegetables, it has no meaning whatsoever. So in fact, if you take levodopa on empty stomach, there's more chance of you having nausea. And that's why I always tell my patients to take it breatheful. But at high doses, if you take high dose of levodopa, then the animal protein starts playing a role. If it's just 1 pill 3 times a day, it doesn't matter, even if you take it with meats. But then as disease progresses, you take more and more, then yes, separating the intake of the animal protein with the medication would make it more effective.
What about the milk product?
No, just the meats. Yeah.
Just repeat. Oh,
You spoke about
it's on?
mood as a side characteristic. Carbidopa is one of the chemicals in the body that helps with your mood, does it not?
Not that I'm aware. No, carbidopa is given alongside levodopa so that the levodopa doesn't break down in the periphery before it gets into the brain. So before it was understood that levodopa needed to be taken along with something, the doses that were required to actually treat Parkinson's was about 10, 100 times more than what are given now. And those doses made people very nauseous, were very hard to take. And so the big breakthrough, and this was back in the 60s, was to combine levodopa with a medication that inhibits the breakdown of levodopa. So the doses that needed to be given were significantly lower, and that's what made it a possible therapy. But in and of itself, I mean, dopamine is a chemical that is correlated with reward and with other issues in the brain.
So how do you deal with mood swings?
So,
How do you deal with mood swings?
so do you feel, what you're saying is your mood swings correlate with your medication when you take the medication?
The lack of get up and go.
Okay, okay. Okay, got it. So I think what you're describing are some non-motor features of the disease itself. So depression is extremely common in people with Parkinson's. One of the most common, what we call non-motor symptoms, as we discussed before. And then there's another symptom called apathy, which isn't necessarily sadness, but it's just this lack of interest and lack of motivation, not really related to mood, but kind of related to what you think, kind of lacking to get up and go. And those two things can be really, really common in people with Parkinson's. Luckily, depression and Parkinson's disease is just as easily treatable in the Parkinson's population as the general population. So things like cognitive behavioral therapy can be extremely helpful. There are studies that show that it's helpful specifically in people with Parkinson's. And then all the medications available for depression in the general population can be used in people with Parkinson's to really good effect. So if it's something that's troubling you, definitely bring it to the attention of your doctor because it's definitely treatable.
Doctors, I have a question from the chat. What can I do when my body shuts down in public? I need desperate tips to get unstuck quickly, acknowledging how the panic of being rushed is part of the problem.
Well said.
Well, I think there are two elements to that question. One is
Can you just speak a little louder?
try. My voice is not, let me see. So I'm saying that, there are two elements that I see in that question. One that I imagine, again, is quite common. So especially people who have tremor, but also for some other symptoms of Parkinson's, it becomes visible when you don't want it to be visible. It becomes visible when you are in a situation where you're public, when you are in a situation where you have to address someone, whether it's a family or work or life. That is because some of the symptoms of Parkinson's are actually changed and somewhat amplified by stress. This is something Dr. Gilbert was referring to. And in the moment, you may have that kind of exacerbation. The second element to that is that, in addition to that, the theme of tonight is, on-off. So sometimes there is a way in which people calculate the best time to perform something, or to be in a specific situation that requires a certain level of performance or engagement. And this can be very unnerving. And a lot of people feels like, they have the Cinderella syndrome. Say, at 2 o'clock, my medication is going to stop working, and I better do everything I need to do or whatever I need to do before that time. But what happens when you are in that situation? So it could be really, really hard. There are rescues. There are ways in which we can try to sort of correct that moment in which the symptoms sort of come back with a certain stressful strength. And some of the tricks are to take, a little extra pill at the beginning of the moment of off or moment of stress. There is an inhaler that we use, which is one of the rescues that has, again, just carbidopa, levodopa, but given on a spray that goes straight to the back of the throat, and from there, in a faster way, reaches the brain than you take the pill. And those are really the strategies that we can use. Well,
Wait, Matt.
I carry the abrasion with me when I go out. If I have a problem, I can inhale and 20, 30 minutes, and I'm fine. Not that it works for everybody, but it certainly works for me. I'm going out with people, I never leave home with that.
You don't leave home without. That's a great commercial.
yes, I didn't mention the name, but yes, the inhaler was referring is what you use.
Okay, so my question was part of this gentleman's question about moods and stuff. But I'm not the one with Parkinson's, but I live with somebody who has Parkinson's. I think I'm more aware of what's going on with him than he's aware. But I hear everybody else talking and very aware of their feelings. But I don't think my husband has always knowledge that he's feeling different. And sometimes, like you're talking about these on and off, and I'm not quite sure if they're on and off, or like he just rains. You know, like it just loses the attention span. And the days, he doesn't have a typical, like, I think a shake, a tremor, doesn't have those things as illness, as times where he's just, he does things, he goes for a walk, he does all those things. But I feel like I'm always saying, get a better routine. When you're on routine, you're better. The sleeping patterns are terrible. The moving around the bed is hard. I don't really quite know if these are changes that require no medication or if this is part of this. And I find this, we're talking about it. No, it's very hard because he is not aware. I'll say it like a lot. So is it possible that people are aware they're doing it? So are these what? Or is this as part of, as our doctor told us, I just have
I'll try to summarize. I think you raise different points and they're all very important. And I'll dissect the question a little bit in some elements. I think in the first part of your questions, to me, echoed a larger theme, which is the disease doesn't necessarily just affect the person who has Parkinson's, the family. And sometimes in a kind of their emotions or how their actions or emotions or words affect the spouses, the partner, the family. It may be sort of a simple explanation because it changes the mimicry, the way the facial expression changes. There may be a different and perhaps sort of there is an interesting sort of understanding of something called the theory of mind. So when we interact, we're kind of aware of the other person's reactions. Somehow, sometimes a person with Parkinson may not be aware of that. May not be aware that, hasn't said thank you. Oh, I love you so much for, doing this kind of things to me. Not because the person is not thankful or doesn't love. It's just that awareness of, the other person kindness or gestures may not be there, or may not be registered, or may not be expressed. And that, I'm sure, becomes really hard in a person, in a spouse, in the context of the family. The second element of the question was, and correct me if I'm wrong, is about the awareness of some of the other, and this may be another way of being on-off. Some of the other elements in which, as again we were discussing before, this sort of variability, this kind of fluctuations during the day or between one day and another, but especially during one day, may not just manifest with the having more trouble walking, or more trouble moving, or more tremor, but more as sort of a change in livelihood, change in energy, change in desire of engaging, change in mood, and there may be a sort of this kind of low of dopamine in the brain that can manifest in that, and may not be so so obvious. There may be sort of little changes that may be more obvious to a spouse, or I don't like the word caregiver. I think now it's been used as a partner, but as whoever lives with the disease or with the person who has the disease. So I hope I addressed your questions.
I could just maybe add one thing, that there are situations where you might not be able to see any fault if, let's say, someone is underdosed. So they never actually in a long period in the first place. They just take some therapeutic dose. In that case, you'll never be in a on state and you don't see fluctuations when you take the medication. Alternatively, there are some atypical variants of Parkinson's that actually do not show this kind of more fluctuations. If someone has not regular Parkinson's, but atypical variant, that they don't exhibit these fluctuations that we're discussing. We're only talking about regular Parkinson's. Even in regular Parkinson's disease, not everybody has tremor. 25% of patients never have tremor, ever, and they only have stiffness and slowness. So it's a diverse disease in terms of what symptoms it shows, and the different variants of that. Parkinson's disease proper is just the most common one. There are some variants that present something different.
And I think another point you were making is we were looking around the room and it seemed like other people with Parkinson's were more aware, but your husband may not have been as aware of what's going on as some other people in the room. And that's okay. We see a lot of variability between among people with Parkinson's, as we do in the general population and everything. So some people will be more aware and some people won't be as aware. We do have some excellent questions that were submitted ahead of time. Yeah. So one of the questions that we did not address yet, which I think we should, is somebody asked, my morning dose takes a long time to kick in, so my mornings are lousy. How do I make my mornings better?
Well, in order to make your morning better, you have to make your night better. So basically, again, it's a loaded question, because if you don't sleep the night, then you'll pay the price next day. So essentially, all your Parkinson's symptoms will be worse in the morning and the entire day if you don't have the next day. But separately, think about it. If you don't take the medication, you don't take the medication during the night. Let's say you take the last dose at 6 p.m. You don't take anything till the morning. You're waking up an empty tank of gas. That's what happens. And then it takes you longer to get going because of these reasons I mentioned in the beginning. You take the pill, and then it sits in your stomach, ready to be absorbed. So you have delayed on, and so there are different ways to address that. So in order to expedite the onset of the action of levodopa, for instance, you can either chew the tablet or put it in carbonated beverage, and then it's going to dissolve and then drink it. You could use the inhaler that the gentleman was talking about. That's a powder inhaler to expedite the onset of symptoms. You also could, if needed, take levodopa in the middle of the night. So let's say you're going to the bathroom in the middle of the night, you could have a pill sitting, a long-acting one, for instance, probably for the night it would be better, sitting on the nightstand, and then you take it, let's say, 2 or 3 in the morning, and that would be the best in the morning. When you finally wake up, you will not be this stiff. So hopefully, and then there are other ways, other medications that last 24 hours. Extended release dopamine agonist, there's some newer class of medications that do last 24 hours that would help with morning woods as well.
Tremendous number of excellent questions on this list, so I'm just going to ask the really good ones. This is a really good one. Are you okay with your patients self-adjusting their own medications, or should they be taking the same every single day?
That's a difficult one to give me because, of course, you know, there is a reasoning that occurs when you know we sit together and decide how much, which medication, what time this needs to be done, and then there is real life. You know, there is the need sometimes to I don't know, have a longer day, or there are more sort of situations that requires more of time, for instance, it requires a little bit more medication. So one reasonable approach to this is to sort of kind of try and understand patterns and discuss possibly with the neurologist, the provider, and sort of reason together what is safe, which is the most important thing. And you know what kind of adjustments can be done in a logical and effective way.
All right, next question. How much and what type of exercise is best for Parkinson's? So I'm sure you all get this question. I get this question a lot. So we all talk about exercise. Exercise is super important, but what exactly should people be doing?
Anything that you will do, and you have to love it, so you keep doing it.
That is absolutely true, and that is usually the first thing I say. But,
Sorry.
however, if you like to take leisurely walks for 1 block and then go back to your house, and that's what you'll do, that may not be enough. So it's better than nothing, but everyone needs to push themselves to the next level. If you look on the CDC, the Centers for Disease Control, they have guidelines about what every older adult should do, with or without Parkinson's. And it's 150 minutes a week of moderate intensity exercise, which is 30 minutes a day, 5 days a week, of something that's going to get your heart rate up. So that isn't a leisurely walk. So it's nice to say that any movement is good, and it is, but really, if you really want the benefits of exercise that we're talking about, you need to get your heart rate higher than your regular activity level, and for many minutes. So that's your goal. Now that could be a stretch goal for you because you're really intoxicated right now. So you can't go from 0 to 60. So you want to make a plan that is feasible, and so that's important as well. So if you don't have an exercise plan now, then what my suggestion would be is to ask your doctor for a referral to a physical therapist. And the physical therapist can assess where you are, give you exercises, and get you started on a program that's going to take you to the next step. Also, another element to this is that getting your heart rate up is very important. That's the aerobic piece. There are other types of exercise too, like stretching, weights can be very important to make sure your muscle mass is intact as well. So we want to mix it up. It's not necessarily only aerobic. And the final piece, and this is something that has to do with boxing and other activities that people do, is that there's some evidence that having a cognitive element to your exercise is good, learning a new motor skill. And so people like do pickleball or boxing or something that kind of stimulates your brain in a different way. So those are some of the elements to think about. All right. Other questions?
Am I on? Or you can just call Susan.
Or you can just call Susan.
Just call Susan and she'll connect you to all these amazing classes that you run.
Absolutely. Susan.
Just put very simply, call Susan.
She'll get you moving. Okay. So we had a question that came in. Can I take CBD or THC, that is medical marijuana, to help me sleep? If so, when should I take it? What dose should I take? And are there interactions with other medications? Okay. The issue of taking medical marijuana for Parkinson's disease is a kind of simple and complex at the same time. Simple is that we don't have the research studies to support use of medical marijuana for any particular symptom of Parkinson's. However, many people use it, and if you actually go to the website of the New York State Medical Marijuana Registry, Parkinson's is on the list. So somehow it got on the list without there being any clinical trials. And so doctors do prescribe medical marijuana for different symptoms. Some people do find that medical marijuana is helpful for sleep in general. And so it isn't completely surprising that it would be helpful for people with Parkinson's who have sleep problems. Now, there are two main chemicals, hundreds of chemicals in the marijuana plant, and two are extracted from medical marijuana, THC and CBD. CBD doesn't have any of the psychotropic stimulation that is associated with marijuana as a drug of use. And so if you're going to use medical marijuana, we tend to push people towards CBD. We give you CBD only, not THC at all. But again, there is no evidence, actual scientific evidence, despite the fact that people use it and some people find it useful. In terms of what's the best dose, when to take it, we just don't know. We can't offer advice because there is no manual for it. And it's a trial and error for people who want to give it a shot. And what you have to be aware of is that it's a drug, just like any other drug. So it can make you too sleepy, it can make you groggy, it can make you more unsteady. And so if you are the kind of person that takes a lot of other medicines or has other medical problems or is elderly, you do have to be quite careful, just like you would with any medicine that's going to interfere with your sleep and make you more sleepy.
Dr. Gilbert?
Yes.
Can each of you, would you mind taking a minute and just sharing your success stories with us? Take a patient, somebody that you have, that you've been working with for a couple of years and you see their successes. Is that, you're shaking your head no, Dr. Shtilbans?
I don't think that's actually any good for any useful.
I'll tell you why.
Everybody is different.
No, but I'll tell you why it is useful. We need hope. We need to know that everybody can progress successfully, and there are people out there that are having successes. It's important for us to know that.
I'll mention one great person. Of course, everybody thinks of Michael J. Fox, but it's not Michael J. But there is a great person in our community. And she happens to be in New York, and I believe you know her. Her name is Pam Quinn, and she's a dancer. And she has had Parkinson's for, I believe, 25 years. And she's someone who tells the story about how she sort of went through all the stages, from being really overwhelmed and thinking, my life is over, to say, I'm going to do something, and discovering how her own background as a dancer, as a choreographer, as a person who moved, really transform her life. Not only that, but she has made this, she has transformed the lives of many other people. So Pam, after 25 years of Parkinson, she's a dancer, she's a choreographer, she dances, she teaches. She has a website that I recommend everybody to look at because she teaches really remarkable tricks on how to overcome some of the difficulty with freezing of gait and so on. And she's an inspiration. She's a person who's always a smile. And I cannot think of anything more inspiring, one of the most inspiring people I've met in my life.
Thank you. That's good for us to hear.
So perhaps on an element of hope, pass it to Dr. Shtilbans, who would love if you talk about some new medications that are, or new strategies in clinical trials, for example, for neuroprotection. So some potential new avenues of what's coming in the future in terms of what may be available in the next few years.
Well, I hope everyone has a room here because we're staying till midnight.
This will be the last question, and then we'll take a break after this. Okay.
It's a lovely question. I would spend an hour talking about this, but basically, so we talked about, the question was about the medications in development as opposed to new approved medications. So we'll just separate this. So a lot of things going on in the research and clinical trials, and that ranges from stem cell approach to pills, to different injections. And I always encourage my patients to participate in clinical trials because not only they can potentially benefit from it, they also would help advance the science. So the stem cells, the issues that is solving and going bullet points because we want to maximize the value of time. So the stem cells, there are 2 points. One is that it has to be injected to the brain, so they have to drill a hole in the brain. And then the second issue is that the previous study showed that stem cells work, they kind of slow progression of disease for 5 years, but then it takes essentially the cells, the transplanted cells, pick up disease from neighboring cells, and then disease continues on. But you kind of get a 5-year break. That's what the previous studies of surgery 120 and that kind of trials show. And there are new trials in stem cells going on right now, specifically. So then in terms of the pills, the different processes that govern neurodegeneration, and that includes neuroinflammation, mitochondrial dysfunction, dissolving protein, alpha-synuclein, and different pharmaceutical companies are trying to develop medications that actually help one of these processes. Unfortunately, they either technologically are unable to do it or fail to recognize that Parkinson's disease is a moving process. It's not like two-dimensional, three-dimensional diagram that's showing the different processes involved. It's a four-dimensional diagram because each of these processes is taking place in each person at different times, different preponderance. So one might be more affected with neuroinflammation, whereas another person's tissue is more mitochondrial in nature. It's not one-to-one. Everybody's different. And so when they're trying to study medication aimed at improving, let's say, neuroinflammation, and they get 10,000 patients, well, okay, maybe 5,000 of them having this issue, but the other 5,000, most of them probably having mitochondrial lesions at that point of the disease or misfolding protein. So essentially, I'm trying to say that the failure of the clinical trials, a lot of clinical trials, could be because the drug that they're studying addresses only one point. And there are a lot of drugs going on in clinical trials aim to, let's say, address neuroinflammation, like LRRK2 inhibitor. That's the gene called LRRK2 when mutated, successfully neuroinflammation. There's LRRK2 inhibitor in phase 2 right now. And the others aim to improve let's say, calcium excitotoxicity, prevents mitochondrial damage, calcium, that failed. So right now, I really cannot tell you, unfortunately, that oh, this is the great trial, this is going to be the winner, because I don't think that addressing one point in the neurodegenerative cascade will translate into clinically significant neuroprotection. So I don't mean to sound very pessimistic, but it's just my take on that. But nonetheless, the trials aim to study potentially your protective condition can slow down disease progression going on, and the best way to find the trial would be to go on that government website called clinicaltrials.gov and www.trials.gov, and then you can just put the diagnosis of Parkinson's disease, put your zip code, and you'll see all the trials near you, because you might not want to go to Los Angeles every week. So you want to find the centers around near you, and then already found, let's say, 10 trials, you can ask the doctor, but what do you think about these trials? Would they work for me specifically or not? Because each of them is, designed to address something different. So you should work with your doctor sort of as a tandem to identify the best trial for you specifically.
Thank you. I want to everybody give the doctors a big hand of applause, really. They're giving us their time and their expertise, and we appreciate it.